Hi, greetings from Taiwan. I'm Johnny Liao. Together with my co-authors, we are going to share a retreatment case of unusual extraction pattern, which was recently published in AJODO. This 21-year-old male patient had his upper first premolars extracted in the prior treatment 9 years ago, but still complained of lip protrusion and chin retrusion. Skeletal and dental class 2, average mandibular angle, minimal overjet and overbite, and procline incisors were noted. The treatment goals were maximal retraction to reduce the protrusion and improve the chin projection to balance the soft tissue profile. How would you treat this case?
The ideal treatment option would obviously be orthodontic surgery to directly address the skeletal discrepancies and normalize the chin profile. Although the limitation of pure orthodontic treatment was fully informed and understood, the patient still declined major jaw surgery. The second treatment option was extracting bilateral mandibular second premolars and maxillary third molars. Upper posterior tests will be used for total arch distalization. However, the amount of maxillary total arch distalization may be somewhat unpredictable and could limit the profile improvement. A third alternative would be extracting bilateral mandibular first premolars and maxillary second molars. With the help of tests, there will be no difference in the final occlusal scheme, no matter which molar was extracted. In addition to the amount of retraction, upper second molar extraction was preferred over the third molars for the potential dewedging effect and may in turn facilitate the counterclockwise rotation of the mandible. The patient chose treatment option 3 to maximize the chin projection. Total arch intrusion of the maxillary dentition was planned with tests. We also suggested the patient could consider chin augmentation as a supplementary cosmetic procedure after treatment.
The primary setup of the working stage included 016 and 022 in stainless steel archwire for space closure with sliding mechanics, maxillary posterior meniscus for maximal retraction, upper and lower subapical anterior tests for anti-bowing and anterior intrusion. After mandibular posterior meniscus installation, the combined intrusion and retraction field systems will form on both arches for maximal retraction and active vertical control. All spaces were closed after 15 months of treatment. Patient asked for more retraction and a more prominent chin. The combined intrusion and retraction field systems on both arches were kept for another 6 months, striving for further improvement. After the failure of maxillary meniscus on the 21st month, a mid-palatal screw was installed to intrude and retract the whole maxillary dentition. This is the comparison before and after 26 months of treatment. Cephalometric superimposition show maximal retraction of anterior teeth and total arch distalization in the mandibular arch. Total arch intrusion with tests on the maxillary arch result in counterclockwise rotation of the mandible, which was beneficial for the post-treatment profile of a patient lacking chin projection. 1-year follow-up records show stable occlusion, and the facial profile was further improved by genioplasty. The progressive profile changes show reduction of protrusion and improvement in chin projection.
I hope you may appreciate the unusual extraction pattern in this retreatment case and the value of tests on active vertical control with the mid-palatal screw and the combined intrusion and retraction force system on both arches supported with tests. In addition, The comparison of facial profile showed us the importance of the interdisciplinary treatment. Please refer to the AJODO website for more details. Thank you for your kind attention.